Welcome to Aspect's site initiation visit. This is a live session that's going to be recorded and it's going to be uploaded to YouTube. Can I just check, can you see this presentation okay?
We can.
Thank you, Maddie. Brilliant. So I'm going to start by introducing the team and who came up with Aspect. So we've got our two chief investigators, we've got Nick Maskell and David Arnold, and then we've got all these names below, which are all the big brains behind putting together Aspect as how you see it today. And then here at the Coordination Centre, so we're the Bristol Trial Centre, you've got myself as the trial manager, we've got Ellen, Beth, Sophie, Rachel, all making up the coordination team, and then we've got our statisticians as well, and we've got Lucy Culliford as our oversight. So a nice big team here. I'm usually going to start with training requirements. Usually this comes lower down in an SIV, but I think it's really important for me to let you know straight away how this is going to work, because it's a bit unusual to most drug studies that you'll do. So here's our training overview. So everyone needs to provide a CV or a competency questionnaire, and then only the PI and the associate PI has to provide a GCP certificate. Everyone must have an understanding of GCP, but the only people who have to provide that GCP certificate are PIs and associate PIs. And that's because we have spliced into all of our training materials GCP principles. So whenever you see a green box or this green tick, then you know that this is something that's covered by GCP. So by doing this training, you are getting an understanding of GCP requirements, and therefore the MHRA are happy that that's the evidence that we need, is that you've done your training. And then just for those specific roles, you have to provide that GCP certificate. So in terms of the study-specific training, there's a few options. So you've got the SIV, which is what you're doing right now, and that's a site initiation visit, which covers everything. Or you can streamline it and just do the proportionate training. So this might be something that you offer to someone who is doing just one particular task on the delegation log or two particular tasks on the delegation log. So we've got separate training for eligibility, prescribing, consent, and safety reporting. So just to kind of go into a bit more detail, so yes, everyone has an understanding of GCP by doing this training, but the only people who have to actually submit that GCP certificate is principal investigators and associate PIs. CV is required, and I did mention you can either upload a CV or a competency questionnaire, and what that means is it's a competency questionnaire is just something that we've made for Aspect, and instead of making somebody sit and write their first research CV, it's kind of like a questionnaire, and they go through and they give us all the information that they require, you know, like their GMC number, and they have to sign and date it just like a research CV as well. The study-specific training, like I said, we've got our SIV slides, which is what you're doing right now, and then we've got the proportionate training for those separate tasks. For consenters, so we either need evidence that you have a GCP certificate or that you've done the proportionate training for receiving informed consent. So those are aspect-specific consent slides, which is important because in this study we're allowing the consent of patients who lack capacity, so it's got some more detail on that. Just a plug for the Associate PI scheme now. So we're really pushing the Associate PI scheme for this study. It's proved very successful so far, so we're really pushing it. The Associate PI scheme is essentially somebody who wants to train up to one day be a PI. And this is open to any healthcare professional, including nurses. So it's a 6-month program where you work through a checklist and it demonstrates your involvement in the study, and your PI at your site would be your mentor. So any healthcare professional can do this, and we would recommend that you only do one study at a time. Usually, you're only allowed one API per site. However, for this study, the NIH are very happy for us to have more than one. In fact, we really encourage that you have more than one. Because pneumonia patients can pop up in lots of different places in the hospital, what we found really works in some of our sites is that they've got 2 APIs or even 3 in some cases, and they're all placed in different wards. Unfortunately, you can't be part of the API scheme if you're specifically funded to work in research, though, so that's unfortunate. You must be able to commit that 6 months, and you need prior approval from your local PI because they will be your mentor. So on to the study overview and what Aspect is all about. So who's involved? Our sponsor is North Bristol NHS Trust. Our funder is the NIHR, making us a non-commercial study, and we are the coordination centre. So we are the go-between between sites and sponsor and sites and funder. We are the people in the middle, and we are the Bristol Trial Centre. So the rationale to the study, so what made them come up with this study? So around 19,000 fatal and non-fatal MACE events happen 90 days after somebody's been admitted to pneumonia. Essentially, people who come into hospital with pneumonia, they are at a much higher risk of suffering from a stroke or a heart attack in those 3 months after that infection. So we know that this risk really goes up, and there's a lot of literature to support this. Obviously, MACE events aren't very good. We don't want people to be having heart attacks and strokes. It lengthens hospital stay, prolongs recovery time, and causes significant long-term morbidity and excess mortality. So the theory here, these patients are at risk of having these cardiovascular events. So what if we give them aspirin? So aspirin, we already know, is really effective in these groups of patients with risk factors of MACE. And we want to test its effectiveness in this study. So we want to give people aspirin who have got pneumonia. We're hoping this will reduce their risk of those MACE events by maybe 15 to 20%. And this would result in thousands fewer MACE events per year. So this is, hopefully quite positive. Aspirin's already commonly used, and any benefit from the aspirin in the treatment of pneumonia, if that ever became legislation, then that would hopefully have very few barriers to implementation, because it's also very cheap as well. So the ASPECT trial, we're aiming to see, does that aspirin reduce the risk of heart attacks and strokes in patients who are admitted to hospital with pneumonia? So we're going to be looking at aspirin versus standard care, and we're going to be only looking at patients who are 50 years and older, and they must have CAP, so community-acquired pneumonia, and not hospital-acquired. And also, we're going to be looking at secondary outcomes, including all-cause mortality, cardiovascular mortality. We're going to look at the major bleeding events because, of course, aspirin, its most common side effect is increased bleeding. And we're also going to look at hospital length of stay. Making our outcomes, looking at MACE events up to 90 days post-randomization. And we're going to be doing this through NHS England, previously called NHS Digital. So we're going to be downloading all of that data from our patients, and we're going to be looking at the ICD codes to check for MACE events in our patients. And then there's our secondary outcomes as well, which I've just listed on the slide before. So the design of the study, it's multi-center, open label, so the patients know what they're going to get, and there's no placebo in this. It's a randomized controlled trial for patients who are admitted with pneumonia. There's also a bit of a pilot study, which I'll talk about in the next couple of slides. The study population will be patients who are 50 years and older, coming to hospital as an emergency with pneumonia, community-acquired pneumonia specifically. It's a really nice, simple randomization of 1-to-1, and they either get the aspirin for 3 months or they don't, and they stick with standard care. So this is the study schema. I'm not going to talk through all the details of these numbers. I just want to highlight that middle in the middle there, which is we're looking to recruit 22,600 patients. So this is a big study, and this will be the biggest pneumonia study that's been run in the UK. So yes, we're looking at big numbers, high recruiting sites. I also want to highlight in this slide that we are aware that most of the patients that you'll be seeing are already taking an antiplatelet. So we're looking at about a 40% drop off from screening just on that exclusion criteria alone. So the pilot set stage, which I just briefly mentioned, this is the first 2,000 patients in the study. So the only thing that is different for these patients is that they will get a questionnaire. So all of our other patients, they are going to be followed up on NHS databases. So the patients won't have to do anything for that. And then just that first 2,000, they will have to do this questionnaire. And this questionnaire comes at day 90 or near enough to there. And they can have it by phone, post, or by email. So these first 2,000 patients, and at the time of this recording, which is the 7th of November, we are on about 560 patients. So we're very much still in the pilot phase. The lead site, though, they are coordinating all follow-up activity. Excuse excuse me. So what you all have to do is very minimal compared to the pilot stage and the main study. So you will need to let your patients know that there will be a questionnaire at day 90. You'll collect their contact details and you'll give out diaries to the patients who are taking aspirin as well. That's to help them keep track of when they take their medication. And just so it's really clear for all sites, we will start a set of countdown emails when we start getting towards that 2000. So a bit more about the aspirin itself now. So aspirin's already licensed for primary and secondary prevention of cardiovascular disease. We all already know that. It's really common in the community. It's going to be used open label, and this makes this a phase 4 study. So it's a post-licensing clinical trial. So we're trying to find new uses for aspirin, making this a really low risk study. Although aspirin is really well known, we use it a lot, it does still come with side effects. The most common one being increased bleeding, and that's linked into our eligibility criteria, so that's important later. We've got extensive experience of using aspirin in primary and secondary prevention of cardiovascular disease. Also, it was developed more than 100 years ago. So we've had this drug around for a very long time. We've been collecting data on this drug for a very long time. So it's got a very, very well-established safety profile, which links into our safety reporting, which is also different for this study. The ASPRE study, not to be confused with ASPECT, they all sound very similar, but the ASPRE study has provided us reassurance that over an extended period of time, the rate of major bleeding events is very low and isn't significantly increased with low dose aspirin. And this study is looking at low dose aspirin. So the intervention in a bit more detail. So the patients who are randomized to receive aspirin, they will be on aspirin for 3 months, starting with a week at a double dose, so at 150 milligrams, which is actually still a pretty low dose, relatively speaking. So they have that 1 week of 150 milligrams once a day, and then they drop down to 75 milligrams once a day for the rest of the course. The control group, or standard care group, means the same thing. They will just be asked to avoid aspirin in that 3 months, unless it's recommended by a healthcare professional that they do need to go onto aspirin. We don't want to stop that. But if there's no indication for it, then we want them to avoid aspirin. Sites, in terms of recruiting and randomizing that patient, you should aim to do this within the first 7 days of admission. That's just because the risk of those MOSE events is highest in that first week, and that's why we've also got that increased dose for that first week. However, if a patient has been in for longer than 7 days, you can still recruit them. It will all go into our analysis at the end, so there's not actually any time limit on when you need to pick up your patients. So the recovery study, they looked at aspirin in respiratory patients, and they used 75 milligrams as well. So we know that this is safe and is well tolerated. And also that 75 milligrams has been used for decades in primary prevention as well. And we know that GPs prescribe this all the time. So it's got an excellent safety profile. We do really, really know a lot about aspirin. Bit of a wordy slide. But in terms of concomitant medication, there's nothing mandated in the protocol that you have to prescribe with aspirin, and there's no rescue medication either. We do say that you can prescribe gastroprotection if you feel that that's necessary, particularly for patients who might be at that higher risk of bleeding. So you could prescribe a PPI if you wanted to. Special warnings and precautions. So this is quite important. Patients who are already taking an antiplatelet, so that would be aspirin or clopidogrel, for example, they will not be eligible to take part in the study. And that's because their risk of bleeding would just become too high. However, if the patient is on an antithrombotic, so an anticoagulant like warfarin, for example, then they could still be eligible for the study. So there's a very important difference there between an antiplatelet and an antithrombotic. So anticoagulants are still considered, and a patient could still be on the study. In terms of numbers for blood pressure, platelet level, hemoglobin level, or any other bloods, we haven't mandated anything in the protocol saying that they have to be within certain values, because this is very much going to have to be treated on a case-by-case basis and will be in the opinion of the treating physician whether they think their risk of bleeding is too high. So we've left that open, and that needs to be judged patient by patient. In terms of the study medication itself, so your local stock will need to be used. So your ward stock or your pharmacy stock or your clinical trial pharmacy stock, that's where you're going to be getting your aspirin from. So we won't be shipping anything out to you. There's no placebo in this study either. So you just need to stick to your local policies and procedures for this. That does mean on the plus side that there's no accountability logs for pharmacy, there's no specific temperature logs for pharmacy either, and there's no placebo. So this really is quite nice for pharmacy. In terms of getting the aspirin, that treatment needs to be issued by prescription, and we're not going to tell you how you're going to prescribe your aspirin. We'll give you the dosing regime, but how you want to actually prescribe that and get that to pharmacy, that is up to you and your site to figure out what's going to be best for your site. Once the participant has been randomized, they do need to start that aspirin within 24 hours. So this is quite a time-dependent study. We do want people to get on that aspirin as soon as possible. So that's why we've got that time pressure here, that once they've been randomized to aspirin, we really want that aspirin to get to them fairly quickly. So if they don't get that first dose of 150 milligrams, then this will count as a protocol deviation. So on the next couple of slides, I've got a couple examples of how you might want to dispense the aspirin and prescribe the aspirin. Just a reminder, so that's that first week where they've got that increased dose of 150 milligrams per day. So that's 2 75 milligram tablets per day, and then it drops down to just 1 tablet per day. So example number 1, this is how they're doing it at the Leeds site. They are using their inpatient drug chart. And I know everyone's drug charts looks different, but this is what it looks like at Southmead. So you can see here they've been prescribed the aspirin at 150 milligrams, and that's for that first 7 days here. It's what those 7 boxes are for. And then it drops down to the 75 milligrams, so not for those first 7 days, and then it continues. If you're using an inpatient drug chart like this, you have to make sure that there's a stop date on there, and that's really clear, because what we don't want is GPs just automatically putting aspirin on their regular prescription. Also make it clear that it's for a clinical trial, so they've written here aspect trial. So on discharge, this is quite handy because it means that whoever's dispensing all their medication to take home, they will just have the exact amount of tablets that they need that's left for their course. Example number 2, this is more classic of a drug study where you prepare it in batches. So all of your medication for your whole time in the study is just boxed up into one box, and you give it to the patient and they're sent off with their box of medication. This is a nice way for pharmacies to do it, because that means that they can pre-make these in batches, and then once they receive that prescription, they can just hand over the box. So a note for pharmacies, we do need a representative on the delegation log. So that can be a pharmacist or a pharmacy technician. So we need at least one of those to be on the delegation log. So they will have been signed off and they need to have completed this training. That lead pharmacist then can train additional pharmacy staff and maintain your own local documentation. Or they can put those additional pharmacy staff on the delegation log. We are happy with either. Medication needs to be requested via the normal inpatient route. And then also, we're not providing a pharmacy site file. Sites just need to follow their local processes. So moving on to screening and recruitment, I'm just going to have a bit of water. So this is a bit of a busy slide, but I'll talk you through it. So we're asking you to screen patients who fit the inclusion criteria and are not already taking an antiplatelet. So when you look at the eligibility criteria, they're all numbered. I've just put the inclusion criteria on the side here. So your patient needs to be aged 50 and over, showing signs and symptoms of a lower respiratory tract infection, and have some kind of radiographic change to prove this. So usually it would be a chest X-ray. So they need to hit those 3 and to not already be taking an antiplatelet. So if they fit all of that, brilliant. Go and screen that patient. That would be fantastic. So we will send you a pad of screening log entries, and it will be 1 page per patient. And in the top right-hand corner, the study ID will already be pre-printed for you. So you can just tear off a page and you've got that study ID in front of you. You can start screening your patient. The study ID will be a 3-letter code for your site. So for the Bristol Royal Infirmary, for example, there would be the BRI followed by the number for that patient. So like I said, they will already be allocated on here. They'll be pre-printed, and I'll show you what the screening log looks like in the next few slides. But first, let's look at eligibility a bit more in detail. So this is a very recent change. Eligibility can now be signed off by doctors and physicians associates, advanced nurse practitioners, or advanced clinical practitioners. So we have opened up who can check eligibility, which will hopefully help sites. Anyone who is checking eligibility, though, must be appropriately trained and delegated by the PI to do so. So the inclusion criteria, I've just mentioned this, they need to be 50 years and older, showing signs and symptoms of a respiratory tract infection, and have some kind of radiographic change to prove this. And usually it will be that chest X-ray. So some exclusions, this is page 2 of 3 in our eligibility criteria. So they can't already be taking that antiplatelet. I've already mentioned that, and I really want to stress it again. They can't be taking an antiplatelet, but an antithrombotic is okay. They can't already have an allergy or have an important adverse reaction to aspirin in the past. And then this one's really important, that they should not be at a high risk of excessive bleeding. So this again needs to be treated on a case-by-case basis and in the opinion of the treating physician. So for example, if they're about to go for major surgery, perhaps putting on aspirin is not a good time for them. We're not including hospital-acquired pneumonia, and we've got it defined what counts as hospital-acquired, because we're only looking at community-acquired. And then this bottom one as well, patients who have been discharged without a decision to admit, they can't take part in the study. So what I mean by that is the decision to admit means that that patient is sick enough to go onto the ward. So we are only looking at patients who are sick enough to go in this study. So if a patient's come into A&E and then they're discharged straight home, they can't take part in the study. However, if a patient comes into A&E and then they are given that decision to admit, so the DTA has been made, at that point, that patient can be recruited. Even if they end up sat on a corridor for hours and they don't actually end up making it to the ward, because that DTA has been made, we are happy for them to go into the study. So last page of exclusions. So these are quite normal ones. So if they're unlikely to tolerate or adhere to the medication regime, if they're a prisoner, known to be pregnant, or if they've got a life expectancy of less than 3 months. So those are all exclusions. And then this bottom one here, if their presentation of symptoms are more likely to be due to COVID-19, in the opinion of the treating physician, then they also won't be eligible for the study. So that's mostly because this is a pneumonia study, this is not a COVID study. So that's one to look out for. And then this bottom one is about co-enrollment, and this is worded quite negatively. We're actually quite supportive of co-enrollment into other studies. However, if that co-enrollment means that the burden on the participant is too high, or it would compromise one or both of the study's objectives, then of course that wouldn't be ideal, so they wouldn't be able to go into the study. We will release to you a list of all the interventional studies that we're happy to co-enroll with. We've already pre-agreed those, and I'll talk a little bit more about that. So just to highlight 2 important exclusion criteria, so we've already read these out, but we're just going back to them. There's high risk of excessive bleeding. So clinicians should use bleeding risk guides to judge this, look at any predisposing factors. For non-medical staff signing off eligibility, so that's the physician's associates or the advanced nurse or clinical practitioners, it must be documented in that patient's notes by the treating doctor that that patient is not at a high risk of bleeding. So essentially, that treating doctor is still making that bleeding risk decision, but we're happy for the non-medical staff to, say that they've read that and this patient is eligible for the study. Now, talking back about co-enrollment, if this patient wants to co-enroll into a non-interventional study, so maybe an observational study, then your local PI can decide that. We're happy with that. If it's an interventional study, though, a randomized controlled trial, then we need our chief investigator to decide that. So we've already got a list of ones that we've pre-approved, but if there are any more that come up, then let us know and we will need to discuss that and see if that's okay. So a little look at the screening log now. So this is what you're actually going to be recording all of this information on. This is what's going to be pre-printed and sent out to you. This is just the top half. So in the top right-hand corner here, you've got the study ID. This is the bit that will be pre-printed. So you would just read this off. The patients that you will actually go through a screening have to have met this first 4 criteria. So the yes, yes, and the no, so not already taking a regular antiplatelet. And then you can go on to the rest. We don't want you to be wasting time on patients who don't fit these first 4 criteria. And then this just follows the eligibility criteria I've just gone through. If you tick any of the grey boxes, that patient is not eligible. If they are eligible, then you'll need to get that signed off and checked by someone appropriate who will then print and sign. This is the bottom half of that same screening log. So we've got some information that we're gathering about language line and translated documents. We've translated our patient-facing materials into Bengali, Urdu, Polish, and Somali. So we're really interested to know whether those are used. We will also give you information about how to use language line as well. And then the actual approach and consent process, this is very standard of clinical trials. You know, we're collecting version and date of the information leaflet that's used. Were they approached for consent? Why didn't they consent? This is all information that's pretty standard. And then at the bottom here, we've got who completed consent. Was it the patient themselves, relative or friend, or an independent doctor? Because in this study, you can recruit patients who lack capacity. And we'll move on to that in a little bit. So a bit more about consent. So we do have a separate set of slides about receiving informed consent, which if you are taking consent in this study, I would recommend reading those even if you do have a GCP certificate, just because they're quite informative about the consent process and the legalities of using a legal representative for patients who lack capacity. So who can take consent? So anyone who is appropriately trained in informed consent can consent onto Aspect. Just a little note here that getting that eligibility signed off and taking consent, we don't mind which order those come in. So you can get the eligibility signed off and then do consent, or you can do the other way around. As long as both of those have definitely been done before the patient is randomized, we're happy with that order. But just a brief overview for the consent process in case anyone's brand new to studies. Patients will be given the information sheet, so patients or the legal representative, and they're given time to consider that information. Then there will be an opportunity for a discussion with the patient or legal representative and the care team or research team. And then if they're happy and they want to go into the study, then they can then consent into the study. So just in terms of the documentation, because we've got a few things going on here when it comes to patients who lack capacity, it does mean that we've got 3 sets of documents. So I'll talk you through which ones you need for which. If your patient has capacity, so that means that they're able to make that decision for themselves, you would give them the participant version of those documents. So you've got the participant information leaflet and the informed consent form. So you'd use the participant version. If your patient lacks capacity, and in this study, we think it's really important to really make that effort to still include those patients because it might be patients on ICU or patients who are quite sick. They're going to be really important for our cohort. So we do really encourage that you do look into this. So let's say your patient lacks capacity, so they're not able to make that decision for themselves. You would need to obtain consent from a friend or relative, or if you're not able to contact a friend or a relative, then you can approach an independent doctor as well. And an independent doctor just means someone who is not on the delegation log for Aspect. So they can then act as that patient's legal representative. And in that case, you would give them the legal representative versions of the documents. Should your patient regain capacity at a later time whilst they're still in hospital, then confirmation consent should be sought. And in that case, you would give that patient the regained capacity versions of those documents. And that's really important because that information sheet will explain to the patient what's happened to them so far and also why it was okay that somebody else made that decision for them whilst they lacked capacity. So in terms of research procedure, so the nitty-gritty now, what you're actually going to be doing. So this is similar kind of flowchart we've seen before. So we've now gone through screening, we've gone through the consent. So now you've got your consented patient and you're ready to do the study data collection. So you'll collect some baseline information from them, and that will be demographics, cardiovascular risk, and their CURB-65 score. And you'll collect their contact information as well, and then you'll go on to randomize that patient. So at the top here, this is just showing what it looks like on the database, and it's separated out into different forms. So this baseline collection form will be on form B, and it's not too bad. I'm going to say this early, that the CRF data entry and data collection, we've tried to really streamline it and only collect what we definitely need. So I hopefully at the end of this can convince you that this isn't going to be a very onerous consent process, getting patients into the study. So on the baseline form, you'll collect demographics, cardiovascular risk, and CURB-65 score. And for anyone who's not familiar with the CURB-65 score, this is a set of 5 questions. And for each yes that you answer, it's a +1. And this basically determines risk factor for the patient. So this patient here, for example, would have a CURB score of 2 out of 5. So then you'd move on to randomization, and the randomization module is actually built into the patient database, so you don't need a separate login for that. It's in the same place where you would do your data entry. So you'd go onto the randomization, which was, like we've said earlier, is a 1-to-1 randomization with no placebo. It's just they either get aspirin or they don't, and they just go on to usual care. So that's performed on the main study database. And to open that randomization module, there's a very specific set of fields that need to be filled in. So if you're a bit pushed for time, we will send you working instructions where it tells you exactly which fields you need to fill in to open that randomization module, and then you can go back and do the rest of the data entry at a later time. So your patient's been randomized, and then you can put that back onto your CRF, which one they've been randomized to. And if they're randomized to aspirin, then you've got a few more questions on that page. And if they're randomized to usual care, then that's it, end of form, and you're done. So in the event of technical difficulties, which it might happen, maybe the online platform goes down, or maybe you can't connect to the internet at that time, we would ask that you call us first. So call the coordination center, and we will be able to randomize that patient for you. If we're also not available, perhaps you're recruiting at the weekend, for example, then you can manually randomize that patient with a very high-tech coin toss. So we will send you instructions as a backup for how to do that, because you need to have a witness, and the heads and tails have already got a predetermined outcome. Great, so you've collected your data and you've now randomized your patient, and they get the aspirin group. So the patients who have been randomized to aspirin, they will be asked to take that aspirin once per day for the whole course, and they'll be told that there'll be a questionnaire at the end of those 3 months if they're in the pilot. And then they'll be given the aspirin group contact card with your research team's details and the FAQ and diary. If your patient's been randomized to usual care or the non-aspirin group, then they will be asked to avoid aspirin for those 3 months. And same again, they'll be told that there'll be a questionnaire in 3 months again if they're in the pilot. And then they'll be given the non-aspirin group contact card. And the difference between those two is one card says, hey, I'm on aspirin, and the other one says, well, I'm avoiding aspirin. And then it's got a handy little list for the patient to refer to, which says aspirin and then other aspirin containing products. So if they're in the pharmacy and they can't remember what it is they're not meant to have, that's a little quick look for them and they can remind themselves. So this is what the diary looks like that you give to the patients who are taking aspirin. So for that first week, 1 tablet is 1 tick. So if you're dispensing this in 75 milligram tablets, so that's 2 ticks, so 2 tablets per day for that first week, and then 1 tick for the rest of the week. We don't mind who fills this in. This is just something you will give to the patient. We will never collect this in. This is a guide for the patient. When we do contact them for their questionnaire information, this will be really helpful for them, because the questionnaire will ask questions like, did you miss your aspirin for 2 weeks or more in a row? And they can use this to help them figure that one out. So they've done their 3 months in the study and they're now in follow-up. So all patients will be followed up using NHS England data. So that's our hospital episode statistics data and also ONS data. So our mortality data, we'll be collecting all that information remotely. Patients in the pilot phase, so that's the first 2,000, they will also get that questionnaire, which again, we've tried to streamline so it's nice and quick for the participant and not too onerous. And then the end of the trial for the participant will be once they've completed their course of medication or they've avoided aspirin for those 3 months, they've completed their follow-up, and then, yeah, so that's the end of it for the patient. And then the end of the trial as a whole will be once all trial participants have completed follow-up, all data queries have been resolved, the database has been locked and analysed. So a little bit more detail about the follow-up. This is specifically aimed at the Leeds site, but I think it's quite useful for other sites to know kind of what is going on behind the scenes in case your patient has any questions about the follow-up. So the follow-up questionnaire is going to be done and coordinated from REDCap. Your patient will be able to choose whether they get this by email, post, or phone. We're really recommending email. It's much easier, and the system automatically sends it out, and the reminders are sent out, and it's really quick for somebody to do on their phone. But it is still their choice. If they want it by post or phone, that is still fine. This happens on or around day 90. Doesn't necessarily happen on exactly day 90. You know, if it falls on a weekend or a bank holiday, then it might be that getting that posted questionnaire out to them might be a bit delayed. So this is what the postal questionnaire is, just the front cover of that, what that looks like. Reminds the patient that they were in a study and that it's we're really grateful for that, and it would be really important for us if they could fill that in. And then the telephone CRF, exactly the same set of questions. This is just where the person receiving the questionnaire information, this is where they would write it down before adding it to the database. So in terms of access, so this Leeds site, which is North Bristol NHS Trust, they're going to have view-only access to all of the participants in the database. So that's your site as well. And that means they can only view it. They're not going to be able to edit anything or change anything with your patient's data. They just are able to view that so they can get those contact details from your patient, so they can call them or send out that postal invite. But for them to be able to do that, they will need to set up an account to do this. In terms of the follow-up staff need to set up an account. We check that, we make sure that they've been signed off properly, they've been trained properly, and we would then approve their access. And then they would use that username and password to get into the database to see everyone's patients. So there's a data upload. We link up the patient database with REDCap. And so that all gets auto-populated, and those REDCap emails can automatically go out. And like I said, it's patient's preference on whether they get that by email, post, or phone. This is an example of what it looks like. We've got either email or by phone or post, and the green ones are the completed ones. So we're going to talk about safety reporting now, and if anyone started to zone out a little bit, this is a great time to tune back in, because this is different to most other drug studies. So because we are splicing in GCP training into this SOV, some of this does feel like it's going a bit back to basics, but it is really important that we all understand the same abbreviations, that we're all on the same page with that. So just to get us going, here's the list of abbreviations I'm now going to be using going forward. So you've got AEs, adverse events, ARs, adverse reactions. Then you've got the serious versions of both of those, so an SAR, SAE. Then you've got this mouthful at the bottom here, which is a suspected, unexpected serious adverse reaction, or a SUSAR, which is probably what you're more used to hearing it being called. And so these are the different types of events. I'm going to go through how these are categorized, and then we'll talk about how this relates to aspect specifically. So I've got this nice little tree here. So your patient has had an event. And the first question you can ask is that event thought to have been related to the study drug? So do we think the aspirin caused this? If it's a no, then that's an adverse event. And then we get to ask, was it serious? And there's a very specific criteria for what counts as serious. So that's not just a self-judgment, but we look, is it serious, yes or no? If it's a no, then it stays as an adverse event. But if it's a yes, then that's when it becomes a SAE, or a serious adverse event. Let's go back to the top of the tree. Has your patient had an event? Yes. Okay. Do we think this was related to the study drug? If we think yes, it could have been related to the aspirin, then that makes it an adverse reaction, because they've had a reaction to that intervention. Same question again, was it serious? If it's a no, then that's an adverse reaction and it stays there. If it's a yes, then that's when it becomes a serious adverse reaction, or a SAR. And that SAR has a special extra question, which is, did we expect this to happen? So did we know that the aspirin had that as a known side effect? And you look at this in the reference safety information. So did we expect this to happen? Like increased bleeding, for example. If that's a yes, then that stays as a serious adverse reaction. But if it's a no, we didn't expect the aspirin to do that, then that's when it becomes that SUSAR, and that's a very special category. So how does this relate to aspect? This is a busy slide again, but I will talk you through it. So the headline news here is adverse events and adverse reactions. So the non-serious versions of those events do not need to be recorded or reported. So you can just totally leave those. The serious versions of those, so serious adverse reactions and serious adverse events, these don't need to be reported in an expedited fashion. So if you've worked on a drug study before, you're probably used to becoming aware of a serious event and you must report it to sponsor within 24 hours. In this study, you do not have to do that. And that is on the basis that aspirin has a really well-established safety profile. We're not expecting to see anything new in terms of its safety profile. We're not expecting to learn anything in that respect. And with that, the MHRA have allowed us to adapt and have this risk-adapted approach to safety reporting. The serious events will still be collected, and that will be collected through our NHS England data. So we will get that remotely because we will look at all of the hospital episode statistics from all of our patients anyway, and we'll get their mortality data. And all those safety events will still be collated and looked at by a doctor for relatedness and expectedness, and they'll be closely monitored as well by the Data Monitoring and Safety Committee throughout the trial. So these safety events aren't being ignored, they're just going to be looked at in a way that's more annually instead of in the live way that we're used to in a drug study. We're also asking you to not seek this information out. You do not need to check in with your patient. As far as you're concerned, once you've consented your patient and you've collected all the data and randomized them and either given the aspirin or not, that's pretty much going to be your involvement over for most of your patients. However, the MHRA were still keen for us to provide a way for SAEs and SARs, so the serious events, to be reported to us if you wish. So we do have a CRF that's for reporting those safety events. SUSARs, though, that's the suspected unexpected serious adverse reactions. Those ones remain as normal reporting, so you do have to report those in an expedited fashion. So if you do think that the aspirin has caused the SUSAR, then you need to let us know as soon as possible, so within 24 hours of becoming aware, and then we will go from there. I'll give a little bit more detail in a bit. So in terms of the criteria, seriousness criteria that has to have either resulted in death, is life-threatening, requires hospitalization or prolongation of an existing hospitalization, or results in a persistent or significant disability or incapacity. That bottom one there is about birth defects and isn't really relevant to aspect. But that's what counts as serious. So if it's none of those, then those don't need to be recorded or reported. So then we've got this question of, is it related to the aspirin? So do we think the aspirin caused it? So people either call this relatedness or causality. So if you're a doctor that's assessing this, you can think, well, when did it happen? Was there a relationship between administering the IMP and the event? Was the effect immediate or was it delayed? Or were there any other possible causes? And then this is a little snippet from the CRF itself. So you've got options like not related, unlikely, possibly, probably, or definitely. And just a little note here that if it's possibly, probably, or definitely, then these all do still count as related. So let's say it's not related, but it is serious. That's a serious adverse event. And these don't need to be reported in an expedited fashion because this is something we will collect with our routine data collection. Did we expect it to happen? So this is that special extra question when it regards reactions that we think were caused by the aspirin. So expected events are listed in section 9.3 of the protocol. It's got this nice big table, so you can have a look through that table to see if it's something that we expected aspirin to do. That's called the reference safety information. And then unexpected events are just anything that's outside of that table. So if it's serious, related to the aspirin, and we didn't expect it to happen, so it's not on that table, then that counts as a SUSAR, and you do need to report that to us as soon as possible, so within 24 hours. And we would also expect a follow-up report to be completed within 5 days of that as well. And here's what it looks like in the CRF. It even prompts you here to tell you which section of the protocol that is in. And it looks like this. I'm not going to read out this whole table, but just to give you an idea, actually aspirin does cause quite a lot of side effects. So these are all the known side effects of aspirin, and we've got that common one at the top here of increased bleeding tendencies. So if you're not sure whether the aspirin caused something, then you can have a look through this table to see if it's on here. So deaths. This might happen in the study. And again, we're not asking you to seek this information out. We really don't want you to be checking up on the patients. We want this to be a really nice light touch study for you. However, you may become aware, perhaps a relative reaches out to you just to let you know that the participant has died. In that case, it is really helpful if you do let us know, because we don't get that mortality data. You know, it might be another year before we find out that that patient has died. So just, particularly in this pilot phase, when we are contacting patients for a questionnaire, it's really helpful for the lead site if we do hear about deaths, because then it stops them contacting a recently bereaved family, for example. In fact, it happened last week. The lead site phoned a family whose the patient had actually died, and they were quite upset that they'd been contacted. So 2 ways that you can report this to us if you become aware. You can either report it on the SAE CRF, or you can report it on the change of participation status CRF. And if you're doing it on the SAE one, then please don't name the form death, still name it as the event that caused the death. And then in this part here, you've got, did it result in death? You can put yes, and then you can put the date there. So that was quite a heavy safety reporting part of the SIV. We're now moving on to protocol deviations. So if you've spotted a deviation or breach at your site, you must report it to us at the Bristol Trials Centre, and we like this on a note to file. We would then assess that to see whether it needs a non-compliance form to be filled in. So the non-compliance form is a sponsor requirement. So if it's a no, no further action will be needed, but if it's a yes, we will make sure you've got that non-compliance form, we'll instruct you to fill that in, and then that gets reported to sponsor. So that's what these forms look like. So on the note to file on the left-hand side here, it's essentially quite a big blank space for you to be able to write about what's happened. And we would expect to see on there the date and time of the event, what the finding was, what your corrective actions were, and what your preventative actions were, which is essentially exactly as what goes on this non-compliance form as well. And if you don't put in your corrective or preventative actions, the sponsor will come back and ask you to go back and fill it in again. So just a warning there. They do like to see what you did about it at the time and how you're going to stop it from happening in the future. So some examples of what might count as a deviation in the study, and these have all happened at least once. So, it's good to keep your eyes peeled and let us know about these, and we can recognize patterns. So some examples. Perhaps your patient has been randomized to aspirin, but they did not receive that first dose within 24 hours. So that would count as a deviation. So we had one site fairly recently where they'd randomized the patient, but actually they didn't have enough prescribers on the delegation log. So they didn't have anyone that was actually currently working that could prescribe that medication. So they got a bit stuck there and they had to wait until the next day. We still kept the patient on the study. That's fine. It does just count as a deviation. Second example here is a member of staff performing study duties before being signed off on the delegation log. This one has actually happened more than I would like to admit. So we're really stressing the training on this, which comes a little bit later because we've got an online delegation log. What's been happening is people make their account and then they think, oh, fantastic, I can go work on the study now. But actually that PI needs to go in and set approve. We'll talk a bit more about that in a bit. And then my third example here is just that patient's been randomized onto the control arm and then they're given that aspirin by mistake, miscommunication. I don't think that one's actually happened yet, so that's good. Serious breaches, now those would be anything that affects the safety, physical or mental integrity of the participants or the scientific value of the study. And I'm really pleased to announce that we've not yet, touch wood, had any serious breaches. So now I'm going to give you a little look at the actual documentation you're going to be using and hopefully convince you that the CRFs aren't too onerous. So on the left-hand side here, I've got a list of all the different CRFs we have, and those first two are the only ones that you're really going to be using for every patient. And then the ones below are only to be used if needed. So in special situations like the regained capacity form, that's going to be quite rare when you leave that one, use that one. We've got that change of participation status form, which used to be called a withdrawal form, but we think it's a bit more nuanced than just you're in the study or you're not. I'll talk about that when we get to that. Got that SAE CRF, which I've talked about, note to file, and then this optional comms sheet as well, if you did just want somewhere to note down when you've communicated with the participant. So here's the screening log. I've already mentioned the screening log and we've already seen it as well, but this is it in its entirety instead of split into two. I don't expect anyone to be able to actually read it. I know it's very tiny and you will be sent this so you can have a little look at this in your own time. But essentially as a reminder, you've got that eligibility criteria up in that top table there. It needs to be signed off if they are eligible for the study. And then we've got that information about the consent process and if they did consent and if not, why not? And on the study database, you'd be entering that into the SL part. and it follows this form exactly. So patients who consent into the study, you will need to take some photocopies. So you'll need to copy that form and put one in their CRF pack, one in the screening log folder, and then another in that patient's medical notes. And then for patients who don't consent to the study, so you get all the way through this process and then actually they end up not going into the study, you can just tear that sheet off and put that into the screening log folder. No copying required. So then you've got this like baseline data collection CRF, which is 4 pages long. This is page 1 and 2. So this first page is just a checklist which doesn't go onto the database. This is just for you as guidance for you, as a reminder. You know, you need to give the patient a copy of their signed consent form, send out the GP letter, just some reminders like that. There's one on there that says consent form needs to be uploaded onto the study database. That actually only needs to be done when we ask you to do it. So it will come up and there'll be an option for it, but you can ignore that for now. That's part of our monitoring, and we will tell you which consent forms we would like to monitor. Page 2 collects patient details. So this collects the patient's identifiers and their contact information. So the identifiers are essential for us to link to NHS Digital. So that's why we're collecting their NHS number and their name and their date of birth, for example. And then the contact details, that's for us to be able to get that questionnaire out for them. But also, if they want the results of the summary at the end of the study, that's how we would contact them as well. This is page 3 and 4. Baseline clinical details on the left here. We've got that hospital stay, so information about date and time of admission. We've got information about their cardiovascular risk, so do they have diabetes? Have they had a previous stroke or TIA? And then that CURB 65 score at the bottom. Then page 4 here, this is the randomization page. So this is when it prompts you to go to the database and fill in the information on this R module here. And then it will tell you whether the patient's been randomized to aspirin or not. If they've been randomized to aspirin, you've got these few extra questions. And if not, then this form ends there. So that's what you're going to have to do for every patient who randomizes into the study. Hopefully that doesn't look like too much. And then the rest of these forms, these are not needed for everyone, but I'll give you a little look at them so you know what's coming in case you do need to use them. So in the database, we've got this regained capacity form, which at the moment for this particular participant is closed off. So it knows from the screening log whether the patient has capacity or not, and this will be open if they did lack capacity. And this is very, very similar to the approach and consent questions on the screening log. You know, were they given the information? Did they consent to stay in the study? So very, very similar information there. We've got this change of participation status form, which goes in the P section, and the blue circle means this is available if you need to use it. So the reason we don't call this a withdrawal form anymore as well, because withdrawal is a bit too black and white. They're either in the study or they're not. I think it's a lot more nuanced than that. So it might be that the patient just doesn't want to take the aspirin anymore, but they're still happy to do the questionnaire and have NHS England data collected from them. So that's what these questions are at the bottom here. That kind of goes into the more detail of which part exactly is it that they don't want to take part in the study. Of course, you might have a patient that says, no, take me off everything. And that's obviously fine as well. The patient can withdraw at any time. This is the SAE CRF. Again, it's the S form and it's available if needed. It's 3 pages, but really you'll probably only use this first page if you do decide to report an SAE, SAR, or if it's a SUSAR, you do have to report it to us. This follows the same questions I showed you earlier about causality and relatedness, expectedness here, and it needs to be signed off by a doctor. And then page 2 is a follow-up report, which would only be needed if it was a suspected SUSAR. And then there's the additional information space as well here. This is what the note to file looks like. So I did talk about how this is going to be used to collect protocol deviation information, but it's also there to record anything that can't be recorded somewhere else on another CRF. So for example, I saw somebody filled one of these in the other day and it said, participant is hard of hearing. So when you do the follow-up phone call questionnaire, you'll be speaking to their wife instead, you know, something like that. This is our co-enrollment CRF. So these are the studies that we have pre-approved that you can co-enroll to. These are the interventional studies, I should say, that we've pre-approved. So we do like to collect information if a patient has been co-enrolled into another study. It's really useful for us, but also for that other study. At the end of our studies, we can compare our lists and see, if there's anything significant there. So we do like to collect that information. If it's a non-interventional study, like an observational study, you just need your PI's approval for that. But interventional studies need the chief investigator's approval for that. So you would have to contact us. This is the comms sheet. It's just a simple space that you can use to record when you're contacting the participant. That is optional. So some CRF etiquette. Data needs to be entered as soon as possible. CRFs need to be completed in black ballpoint pen. Tick boxes need to be marked clearly, and all fields need to be completed. So it's much better to complete a field rather than leave it blank. If you don't know the answer to something, it's much better to write not known rather than leaving it blank, because otherwise it just looks like you've missed it by mistake. And then each page of those CRFs needs to be signed and dated by the person completing that form. And then this bit at the bottom here, it's slightly blurry, but I think it shows you exactly what we're trying to say here. This is a very golden GCP standard. So we do not allow Tipp-Ex. So if you've got a correction you need to make, no, Tipp-Ex is never allowed in clinical trials. No scribbling it through, no crossing it through that we can't see what's underneath. The GCP gold standard way to do this is a single line through, put the correction next to it, and then you must initial and date it. And believe me, they do look for those initials and dates. As someone who's been audited before, they really do care about that. So please initial and date any corrections that you're making. So we're almost there. We're going to talk about the databases now and what it is you need to do next. So I've just given you lots of information about the study, why we're doing it, how we're doing it, forms we're going to be using. So now you're going to be thinking, great, what do I do now? So there's two systems. So this is very important. They are two separate databases. They look exactly the same when you're trying to log into it, but they are different and you need a login for both. So you've got the trial management system, or we call it the TMS, and that's staff management. So we've leapt into the future, and we have an electronic delegation log and electronic training log. This is also where you upload your GCPs and your CVs. And then you can also look at site file documents there as well. You can go in and download documents for your own site file. So everyone who wants to work on Aspect has to make an account on the TMS, because that is essentially the delegation log. We need to make sure that all our staff are trained and signed off. The patient database, this only needs to be filled in, well, you only need to make an account if you're somebody who's going to be doing the data entry or randomization. So that patient database is the CRF data entry, randomization, it's also the consent form upload. So you will only receive access to this account that you've made once we know you've been signed off on the delegation log. So that's really important. You must be signed off by your PI before we'll let you, look at patient identifiers essentially. So a little bit more about the trial management system. So like I've said, that's our online delegation and training log. It's our repository for those documents that you'll need to upload. So how it works is you will create a new profile and it will go through your role, what your delegation tasks are, what your relevant training is, and it will ask you to upload documents. We then check that to make sure that you've been correctly trained and that you filled that in properly and that we've got the correct evidence. So we approve that, and then your PI will get a notification to say somebody's ready to be approved. So your PI can log in anywhere they are. So if they're on holiday in Madeira, then they've got no excuse. They can still log in and they can still sign off people to work on the study wherever they are. Once you've been signed off by your PI, you can then log back in and look at the master site file. And that's where we will upload all of our documents, so the patient-facing materials, insurance documents, ethical approval, all those sort of things. You're going to need your investigator site file. You can go in, log in, and just download them from there. Sites are expected to set up their own investigator site file, but we are flexible on whether you do this electronically or on paper. I guess it will depend on probably your trust's rules on that. We do recommend that you do the training and then you sign up to the TMS. And that's essentially because if you go away and do your training whilst you're midway creating an account, it times out after 10 minutes. So you'll just have to start again if it took longer than 10 minutes. So making an account, this is what it looks like. You've got this nice register here button. You'll generate a username and password, and then you will be asked what your role is on the study. So here's our roles that are available to Aspect. There's got a difference there between our principal investigators because we are allowing nurse PIs as well, so either a medical PI or a nurse PI. And then you'll be asked to put your center, so that's the hospital that you're working at. And like I said, this will time out after 10 minutes, so don't wander off. Then ask you about your delegation tasks. And so you would go through and tick the ones that are relevant to you. It does look like there's some missing numbers, but that's very deliberate. So depending on what role you've selected, it will hide some tasks, because if you've selected admin, for example, we don't want you to accidentally say you're going to prescribe the aspirin. Then it will go through training with you. You know, have you attended an SIV? So everyone here, yes, you have. You've done an SIV now. And it will go through the other training screens as well for proportionate training. It will then ask you to upload any documents, so GCP certificate. So just a reminder, only the PIs and APIs have to upload their GCP certificate, but you're very welcome to if you do happen to have one. And everyone needs to upload their CV or competency questionnaire. Date of training gets recorded on here as well. Your CVs need to be up to date for every 2 years, and GCPs last 3. Just a note to say you will not be able to log back into the TMS until your PI has signed you off. So we have to check it, and then your PI signs you off. So we get people making duplicate accounts because they think, oh no, I can't log in, and then they end up just making more. This is what it looks like. So this is a little screenshot I've taken from a site where a lot of their staff have been signed off. So it goes this nice green. That's when you know that staff has been signed off. So you've been signed off, you're now able to log back in, and logging back in, you can look at the delegation log, or you can go into the master site file, which looks like this. So this follows the exact same format of the checklist we're going to give you to help you make your site file, and it's got all the documents you'll need in there. So that was the staff management database. Now this, the patient database, is separate. This is where patient identifiers go, where the CRF data entry happens, and where randomization and consent form upload happen. So to access this, first you have to be on an NHS computer because it needs to have that secure server. It won't work if you're not on an NHS computer. And you must be approved on the TMS. So you must have been signed off on the delegation log essentially and been delegated this task as well. So we approve that and check that. And just like any other patient database, queries could be raised by us about missing data or anything that needs correcting. So I'm not going to go through the whole of the database. I'm not going to show you endless screenshots. We've got working instructions, so it's kind of like cheat sheets. So if you do need a hand or some guidance whilst you're doing this, they are available. But I did just want to highlight adding a new patient and what that looks like. So on your screening log, the study ID looks like this. You've got a 3-letter code, hyphen, and then the number. A little quirk of the patient database, you just need to remove that hyphen, so it becomes an unhyphenated study ID. So you would put that into your study ID bar and click search. It would come up with nothing. So it then offers you this option for inserting a new patient. So that's when you click that nice green cross, and that's when you can start adding the information. So last part, and then we will stop for questions. So that's a lot of information. You might now be thinking, right, my site isn't set up yet. What's left for us to do? And then we've probably got some people on a call where their site is open, and that's great. Welcome. So you can probably zone out for this bit. But this is our green light checklist. So this is exactly what we're checking to be able to green light your site. So your study team needs to have completed the delegation and training log. So on the trial management system, we're looking at all tasks on the delegation log being covered. Staff have been appropriately trained. We'll be checking CVs and GCPs. And we need that proof of the key site staff. So as a minimum to open your site, we need PI, research nurse, and a pharmacist or pharmacy technician. You also need to have finished your site file creation. So we will give you a checklist, and that needs to be completed and returned to us to prove that you've made your site file. Study documents need to be localized, and you'll send those to us. Feasibility and contact details form needs to be completed and returned. If you've made it to SIV stage, it's likely that your site or your R&D has already done this, but just to be aware, those forms need to be finished. Your PI needs to have signed off the protocol, and we also need to have had the contract signed and agreed. And in this study, we're using the model non-commercial agreement. And then finally, we need confirmation from your R&D that there is local capacity and capability to deliver the study. So that's our exact checklist. Here's our contact details. I'm pretty sure you've all got our email address, but we're also really active on Twitter, or I should say X now. And we do release monthly leaderboards of studies of the sites that are doing the best, and also other important announcements go on there as well. All right, I'm going to stop now and take any questions. In fact, I'm going to stop the recording.